All right, so aerosol generation and mitigation in dental practice. This is March 25th, 2025. This is a live presentation unless you're watching this at a later date, of which that would be a recording. To receive CE credit, if you're watching the recording later, please scroll below this video to the instructions section and you will see a link to the quiz and the handouts. There's, for our live audience, a link to the quiz. And again, I will be speaking following this presentation. We'll have Glory Dolphin Hamas join us. We're going to identify procedures that are high risk for aerosol production, describe transmission precautions for aerosol generating procedures, implement administrative controls and engineering controls to reduce aerosol in your practice, discuss technologies to assist dental practices with aerosol mitigation. And if anytime you have any questions for me, please type them in the chat area. I can't guarantee I always have the answers, but I try. And if I don't, I will try to get the answer for you. So many of you know I teach many different infection control courses on our platform and for other companies. 1 Saturday to 2 Saturdays a month, we offer infection control. It's a 3-hour training. I also teach a course on water, dental unit water line and water safety, hand hygiene, surface disinfection. Tonight is aerosol. And I always start with the chain of infection because this helps us to understand how disease transmission occurs in our dental practices. And it always starts with a pathogen. So if you look at the chain of infection, which we have here on the screen, these are links. And we want to disrupt one or more of these links so that we can disrupt disease transmission. We don't want to maintain the links. We're here to disrupt one or more of those links. And for this evening, we're going to talk about aerosol. Now, the chain of infection always starts with a pathogen. It could be bacteria, virus, fungi, or parasites. That pathogen needs a reservoir to divide, replicate, proliferate, and so forth. That can be humans, animals, soil, food, and for this evening, we're going to be talking about air and water. Portal of exit is a way for that pathogen to escape its host. So that would be through coughing and sneezing, perhaps. It could be through bodily secretions, feces, and then a mode of transmission. We need a way to provide transport to that pathogen from one host to another. And we're trying not to give it a whole lot of help in our dental practices, but you'll see that the number one mode of transmission would be your hands. And even though you're wearing gloves, your hands can still transmit transmission. So one of the courses that I do provide is effective hand hygiene. It's important. So gloves don't save us. We have to deploy effective hand hygiene. That can be through direct contact, indirect contact. We're not going to talk about vectors, but enough to say that vectors would be rats or insects that harbor that particular pathogen, ticks, for instance, mosquitoes. Portal of entry would be a way for that pathogen to re-enter a new host. And that can be through the eyes, the nose, the mouth, or cuts in the skin. And so we use PPE, right, to protect our portals of entry. And then we need a susceptible host. We need someone who is not immune to whatever disease this pathogen could cause, whatever infection that might be. And we have populations that are at greater risk. So certainly if we do not have innate immune to a particular pathogen, meaning we weren't exposed before, we don't have any antibodies to protect us, anyone could be infected with that particular pathogen. But a susceptible host might be the immunocompromised. So if we have a patient who has a rheumatoid arthritis, or they're being treated for cancer or HIV, etc., they could have an immune response that is suppressed. And if they come into contact with contamination in your dental practice, they may be more prone to becoming infected than someone who is not, someone that does have a robust immune response, right? Infants, because their immune response would not be mature yet, their immune system is not mature. And then our older adults, as we age, our immune response is not as robust. So older adults are at greater risk for more severe illness, hospitalization, and death. So we have reason, we have cause to make sure that we're doing everything possible to protect not just ourselves, but our patients as well. And by doing so, by protecting ourselves, we're also protecting our family members at home, because these pathogens don't just stay in your practice. They can go home with you and they can infect your family members or whomever you live with. For those of you that joined us a little bit late here on the live presentation, please go to the chat area and access the quiz instructions and the course folder, please. Again, for those of you watching this on demand later, please scroll below the video player to the instructions section to access your quiz and your handouts. All right, so that is the chain of infection. And that pertains to any situation, whether we're talking about aerosol, we're talking about water, we're talking about surface disinfection, and so forth. Okay, so potential routes of transmission of disease in a dental office can be through direct contact with body fluids of an infected patient, whether that's blood, saliva, contact with environmental surfaces or instruments that are contaminated, and we're all here today to talk about contact with infectious particles from the patient that have become airborne, i.e. aerosol. So aerosols are classified according to particle size. We're going to be talking about spatter this evening, and by the way, this is all on your quiz. So I would follow the quiz as a study guide and get it completed right now. The spatter are the large particles. These are greater than 50 microns. They're heavy, they're clunky, they're ejected from the patient's oral cavity, for instance, and they're not going to travel that far, but they are packed with quite a bit of energy. And if you were outside with these particles, they'd behave like a bullet, like ballistics. The trajectory would be like an arc, but because they are in an enclosed area, usually your operatory, they're going to bounce around after they leave the patient's mouth, and they're going to bounce off maybe your face shield, your arm, a wall, etc., till they run out of energy, till gravity brings them back down someplace they're going to land. Where are they going to land? Nobody knows. It could be on a countertop. It could be in your hair. If you're someone that doesn't like to cover your beautiful hair, you're taking this home with you. Your arms, if you're someone that does not cover your arms chair side, your arms are literally littered with aerosolized particles. Could be the patient's tray, could be your flooring, again, anywhere in your operatory. Unfortunately, those particles, although they're large, can still become re-aerosolized. You walk past a countertop, your HVAC may turn on, you turn on a high-speed handpiece, whatever the case may be, and they can flutter away and go someplace else. But they're not going to stay in your air, in your operatories for very long. Again, they're going to fall back down to earth somewhere. Now, droplets are less than or equal to 50 microns. So that would be the next size down, if you will, in diameter. And that makes them fairly light in mass. So they're going to hang around in the air currents in your dental practice for up to hours, sometimes indefinitely, until they land somewhere as well, maybe on another surface, etc., in your hair. Maybe you might inhale it. Now, droplet nuclei are the evaporated droplets. So those are less than or equal to 10 microns in diameter, so very light in mass. And they also can hang around in your operatories for quite a few hours, and eventually they're going to land somewhere. but also very light in mass. So they'll settle on an environmental surface, or they may enter your respiratory tract. So we know that particle size and how deeply it embeds into your respiratory tract are related. So the smaller the particle size, the more deeply they will embed when we inhale them. So the large particles, greater than 5 microns or more, tend to deposit mainly in the upper and large airways. So there are structures in your respiratory tract, as well as your nasal passages and so forth, that can limit the amount of that type of aerosol delivered to the lung. Now, the particles that are 2 to 5 microns deposit preferentially in the central and small airways. So they can embed deeper because they're smaller in diameter. They can bypass some of the protective features of your respiratory system. Now, the small particles, less than 2 microns, deposit mainly in the alveolar region. So that's very, very deep into the respiratory system. Spatter is going to bounce around. Spatter would be like shooting a bullet in your operatory. It's flying out of the patient's mouth or from the high-speed handpiece, or maybe your ultrasonic as well, but mainly from the patient's oral cavity. So it's not going to hang around in your air very long. It's going to bounce around and run out of energy and land somewhere, probably on a surface or in your hair or on the patient's tray. Here are some images of pneumonia, and I put these in here just so we have some frame of reference because, of course, COVID-19 has been in the forefront for the last number of years. But we've also had a resurgence of pneumonia and RSV, respiratory syncytial virus. RSV is hugely alarming for older adults and young children. And then bacterial pneumonia that can occur from sometimes as a secondary infection, and COVID-19. So COVID-19 has a characteristic broken glass appearance on imaging. And for those of you that have never had pneumonia, I had viral pneumonia as a child, and it took months for me to recover from that. There was a flip side. I got to stay home for a few weeks and read every Nancy Drew book that was ever published. That was my thing, reading at the time. I'm sure that doesn't surprise many of you. But viral pneumonia, again, antibiotics is not going to work. So the patient's immune system has to be intact so that they can recover. And then bacterial pneumonia is often treated with antibiotics. COVID-19 is viral, so antibiotics not going to help COVID-19. Now, again, if you have any questions or concerns or comments, please type them into the chat area. This graphic is size distribution of exhaled aerosol particles containing SARS-CoV-2 RNA. And you may have heard this early on in the pandemic, but I have this here just for reference because of activities and how they are related to symptom onset. Singing, talking, and breathing. Understand that the field of dentistry, the occupation of dentistry and dental practices are very procedural, right? If you go to a physician's office, the best you can hope for often is that you either have a nurse practitioner or maybe a physician enter the room now. They're going to take your symptoms. They're going to enter those into a laptop, or they'll have a scribe do that for them. The aerosol that they're concerned about is either you talking or tidal volume breathing, or if you have a cough or a sneeze or something like that. They're not working necessarily with machinery that creates more aerosol, or certainly machinery that's connected to an air and water system. So dentistry is quite different from all other healthcare practices because we are really embedded in aerosol all day long. And it is an occupational hazard. But for these activities, singing, talking, and breathing, singing, of course, emitted the most particles, and they were talking early on when they closed churches and so forth, or advising churches, the chorus not to sing. Talking, followed by tidal volume breathing, and then days from symptom onset to the right. So what do we see? Singing came in number one for days from symptom onset 1, followed by talking and then breathing. And then particle size here. So we can see that the particles here, 1.7 to 2.8 microns, and the activity of singing had the most of that size particle. However, we're going to see in our healthcare practice of dentistry that we need to be worried about a different kind of particle that I haven't mentioned yet. And we're getting there. Unfortunately, now, because we're not testing for COVID or recording these tests with public health departments, if they still exist, National Wastewater Surveillance System. These are metro areas that have agreed to share testing of their wastewater from their wastewater plants, and they can understand quite a bit the level of transmission in their area that way by looking at wastewater, right? So in this case, it's COVID-19, SARS-CoV-2, the virus. But they also test for other things as well. And flu, for instance, influenza A, because people create waste and they're shedding viral particles or they're shedding bacteria. That's how they are also following bird flu as well. So these are just different areas. And I used this probably from a year ago, and there's a link. So that tracker will bring you up to date. Not all metro areas participate in this. All right, so spatter here. Spatter is defined by Mysick and colleagues as the large particles, larger than 50 microns in diameter. If you think of a micron, that is 1/1,000,000th of a meter. And these particles, again, behave similarly to ballistics, to bullets. So if you have these particles in an enclosed space, again, they're going to bounce around and finally come down to earth. They're ejected forcibly from the patient's oral cavity, usually, and they arc in a trajectory similar to that of a bullet until they come into contact with a surface or gravity brings them back down. They are too large to become suspended in the air, so they're airborne only briefly. And again, that is a question on your quiz, so I recommend accessing that quiz right now. Now, droplets and droplet nuclei are sequentially the next smaller particles. We said droplets can remain suspended in the air until they evaporate. And when they evaporate, they become droplet nuclei. So droplet nuclei are highly condensed droplets, and they are usually highly pathogenic, and they can contaminate surfaces in a range of 3 feet and may remain airborne for 30 minutes up to 2 hours, and some say even longer. The problem, again, is that if we inhale these particles, and we do, the droplet nuclei can penetrate very deeply into the respiratory tract. But now, here are the particles that I want you to really pay attention to, because in dental practices, and you'll hear Glory talk about this too, fine particulate matter, ultrafine particles make up about 90% of the particulate matter generated in dental practices. And because they are very small, they're believed to exert higher toxicity than the larger particles. In fact, they're smaller than 0.1 microns in diameter, and they're small enough to pass through the lung tissue and actually enter the bloodstream, circulating like oxygen molecules. Ultrafine particles, which are present in the air in large numbers, pose a significant health risk. And I know many of you may have been in wildfire areas and you were concerned about ultrafine particles, or you've heard of these, but they generally enter the body through the lungs, through the respiratory system. They enter the bloodstream because the lung tissue and the respiratory system itself, because these particles are so small in diameter and so light in mass, will bypass all of the protective features of the respiratory system. And again, they enter the bloodstream and circulate like an oxygen molecule, and they can translocate to essentially all organs. Compared to fine particles, they cause more pulmonary inflammation and they are retained longer in the lung. Now, the concern about ultrafine particles, especially for us as dental clinicians, is not just the aerosol from patients or organic material, but also the inorganic material that we create by grinding on composites, other acrylics, zirconium, and so forth. Very toxic. Also, and you'll hear me talk about this again, if you are not treating your water lines, testing your water lines, shocking your water lines, and you have no idea the quality of the water that you're using, you are creating a hazard, an aerosol hazard. It's even worse. And the problem with that is that if you have bacteria inside your water lines, or viruses or fungi, they are now emitted in these ultrafine particles attached to some of this inorganic matter, and it's highly, highly, highly dangerous for us. And again, about 90% of the particles in your dental practices are ultrafine. And they've been linked to other chronic illnesses, or increasing the probability of chronic illness as well. Repeated contact with extremely small particulate matter, the ultrafine particles, can trigger heart disease, diabetes, cancer, neurological disorders, and respiratory ailments, especially among children and those with long-term occupational exposure. And you all are in that. I don't think you're children. I think you are the ones that have the long-term occupational exposure. So let me give you an example. About a year ago, I'm in public health, and I had a dentist reach out to me who was hospitalized for a pneumonia called Pseudomonas aeruginosa. And you may have heard of this. It's a waterborne bacteria. And it's a very common waterborne bacteria, especially found in dental unit water lines that are not monitored properly, not tested, not treated. And it's a common waterborne contaminant in many different water systems, not just dental water systems. The three that we're most concerned about is Pseudomonas aeruginosa, Mycobacterium tuberculous, non-tuberculous Mycobacterium, excuse me, I got that switched around, and Legionnaires pneumophila. Those are the three that we're worried about in our dental unit water lines, but there are many that we should be worried about. So he reached out to me. He had been hospitalized for several weeks with this pneumonia. It was like a mystery illness to him. And he said, Kirsten, he said, apparently it entered my leg, because the doctors found a very large nodule on my leg that they removed that was also a Pseudomonas aeruginosa infection. And he said, I've never injured my leg. He said, I don't know how it would have entered my leg and infected my lungs. And I advised him it could have very well been the other way around, and probably so, knowing what we know about Pseudomonas as a respiratory illness. He may have inhaled ultrafine particles, translocated to other tissues, and the body's way of protecting us is to wall off that infection, right? Fibrosing it, if you will, creating this nodule so that it couldn't infect the rest of his body. So that may have been the cause of that infection. Of course, this is anecdotal, but I'm sharing that story with you. Are there any questions as we move forward here? Splatter and spatter are the same terms, and they're used interchangeably in the literature. Melanie, you may want to put your quiz in a different browser, and it will be sent to you afterwards. It's spatter or splatter, interchangeable. Access code has not been posted. Please tap on that red banner to get your instructions. It'll be posted at the end. What about Cavicide? So I will tell you, I'm not a big fan of Cavicide, and not the product itself. I'm not a fan of the chemistry, which is a quaternary ammonium compound. So it's not to say that it doesn't do its job. It does when it's used properly. Most of you have been told to use 3 wipes per operatory, which there is no way that you can disinfect properly your operatory with 3 wipes. Let's just face it, that's not going to happen. But my biggest concern is that quaternary ammonium compounds are highly toxic. And when I first started in dentistry in 1981 as a dental assistant, I was in high school. I should tell you I was an infant, but I'll be lying. I was in high school, and when you walked into a dental practice, you smelled eugenol, so cloves, and because we used it in cements, and you smelled copalite. And there's probably maybe 3 of you here tonight that know what copalite is. Copalite was a varnish that we used under amalgam restorations so that the amalgam, the silver, did not stain the tooth. So if you placed an amalgam, it could enter and seep into the tubules and turn the tooth gray or black. So we used copalite, which was a varnish, and it smelled like, I don't know how to describe it, but very strong, like alcohol almost. Those are the 2 things that you smelled walking into a dental practice, which kind of made some of the patients a little fearful of going to the dentist, right? It was a trigger. What do you smell now when you go into a dental practice? You smell Cava wipes, because about 95% of the practices are using Cava wipes or Cavicide or something in the quaternary ammonium compounds. And honestly, you don't want to be smelling any of it because it's highly toxic to your respiratory system. And the concern here is that they're also toxic to your reproductive system, your immune system, and so forth. There was a study that came out a year ago that talked about the fact that the concern was the quaternary ammonium compounds, we call quats, are not highly regulated either. And many of you are just using your regular medical grade gloves to wipe down your operatories, and quats can disrupt your DNA, right? Inhaling it, getting it in your skin. So use utility gloves when you're using those wipes. My other concern about the wipes is that they're, for the most part, not being used correctly. They're not making contact time long enough, and they're not sporicidal. So many of the diseases that we're concerned about form spores, like Clostridium difficile. And we cannot kill Clostridium difficile spores with quats. So that is my concern about that chemistry. Now, does it kill what it's supposed to kill? Yes. But it has to be in contact for the right amount of time. And if you're using 3 wipes per operatory, I would bet my last dime in Las Vegas, if we cultured your operatories, we'd find out, and you'd be horrified that they were very contaminated. You don't need the access code to get the quiz. Go to dentalceacademy.com/quiz. You can go to our website, tap on quiz, or scroll up in the chat area. You'll see the instructions. Or access the red banner at the top of the screen. Go to this handout and you'll see the quiz access as well. How long does it take to disinfect an operatory, would you say, Dr. Rowling? If you use hypochlorous acid and an electrostatic sprayer, 4 minutes. and you're going to kill more than you'll ever kill with 3 cava wipes. I know, good old Copalite. Yep. Ether. There you go. Exactly. So hypochlorous acid is what I recommend. I'll put it in the chat area. My office requires we pour it over 4x4 gauze in a jar and then use it. That's even worse. Okay, so let me, Alan, for those courses, there is no passcode. All right. So let me put in the chat area, since I got off topic here, because this is something I talk about in a lot more detail in the infection control course, and our surface disinfection course, and our C. diff course, Clostridium difficile course. But hypochlorous acid, and you're going to find it on EPA List K, which is effective against Clostridium difficile spores. That is considered the standard. Now, your tubs will say, your microfiber tubs will say that this product kills Clostridium difficile. That is misleading. It kills it in its vegetative form, which is anaerobic. So the minute it hits oxygen, it's going to die on a moist countertop in a couple of hours. The spores will not. In fact, when you spore test your autoclaves, your strips are Clostridium sporogenes, because Clostridia is very difficult to kill. So you need heat and pressure, or you need a chemistry that's going to kill them. And in some studies, these microfiber towels actually cause more surface contamination because of cross-contamination. You're just picking up things that they're not going to kill, and you're moving them someplace else, usually the spores. So hypochlorous acid is found on EPA List K, and the manufacturer is called Earth Clean, Earth Safe, or EvaClean. And it's a Protexis electrostatic sprayer. And if you have any questions, reach out to me through the website, and I'm happy to get you pointed in the right direction. I don't make a dime off those products or any of these products. It has to be on EPA List K. Why? If you go to Amazon and you pick any old hypochlorous acid, or you're making your own on a countertop generator, it's not going to be a sufficient concentration to kill those spores. So EPA List K tells you, yes, tests have been done, and hypochlorous acid A is non-toxic. Your body produces it. It's used for wounds. It's used for veterinary care. It's used in oral rinses. So it's very, very safe. And many of you may have been using it for your aerosol early on in the pandemic, and I would recommend go back to it. It's great stuff. Okay, so we got a little off topic, but sort of related to aerosol, because you don't want to breathe in cavicide or any quaternary ammonium compound. Optum whites are not effective against C. difficile spores. I believe Optum is hydrogen peroxide. They may have one of their products that might be. Look at EPA List K. You can just search on Google. It's going to come up, or take our infection control course. And you can take it on demand as well. All right. So again, we are concerned here about the inflammation and chronic illness that can be caused by these ultrafine particles. Even a brief exposure to ultrafine particles can have cardiac effects, even in folks that have never had any cardiac issues. In middle-aged individuals with metabolic syndrome, exposure to the particulate matter 0.1 microns for 2 hours caused electrocardiographic changes, a decrease in blood plasminogen and thrombomodulin, and an increase in C-reactive protein and serum amyloid A, indicating an inflammatory process. So keep in mind in your practices, about 90% of the particulate matter is ultrafine particles or are ultrafine particles. This was ultrafine particles exposure associated with specific operative procedures in a multi-chair dental clinic. And the concern here is the large surface area to mass ratio that allows these particles to act as carriers of toxic chemicals. So usually in the dental practice, they're attached again to composite materials, zirconium, and so forth, silicate. So large variety of compounds that attach to these particles likely to be a major cause of their toxicity. In dental practices, ultrafine particles are abundant and are mainly produced by intraoral grinding, polishing, dental resin material containing nano-sized particles, such as pyrogenic silica, zirconium dioxide. Susceptibility of the host. So susceptibility of the host, again, we spoke about some populations that may be more susceptible if they come across contamination in our dental practice from aerosol. And that has to do with virulence of the organism, the dose, how much was inhaled, and the pathogenicity of the microorganism, as well as the host immune response. And this is a graphic that just details if you had a patient, let's say the infected individual is a patient, and many of our patients can be carriers. They're not even aware that they are ill, or they may have been ill in the past and they're still capable of transmitting that infection. I may be one of those. I had a Clostridium difficile infection that followed a dental procedure. I may shed spores for the rest of my life, right? So I use hypochlorous acid in my home, in my vehicle, in my offices. So let's say this patient walks into your practice and they may be shedding virus in respiratory and fecal discharge. Norovirus right now is at an all-time high. That is fecally discharged, and it is a virus, the cruise ship virus, very contagious. Call it the stomach bug, right? So the patient or whomever has come into contact with this may have contamination on their hands, on their clothing. Certainly that can be the case with C. difficile. They might be using your bathroom. When you flush a toilet, you are creating aerosol. And droplet nuclei can form and travel over long distances through our aerosol. We spoke about droplet nuclei being the evaporated form of the droplets. Also, it can come into contact. We can come into contact with direct patient care and indirect contact with surfaces that have become contaminated with aerosol. Anything that you've left out on your countertops and so forth are exposed to the aerosol, and we'll talk about that. So where does the aerosol source come from? Dental instrumentation, saliva, respiratory sources, dental handpieces, ultrasonic scalers, and our three-way air-water syringe in combination with the patient's saliva. Let's see a few questions that popped up here. So how are we safe working in a dental office if cavicide wipes are being used? Well, you protect yourself and you follow infection control protocols. You have adequate ventilation. You have adequate filtration. You're wearing the right gloves when you're breaking down the operatory. Utility gloves, heavy-duty utility gloves. You're wearing a mask. That's how you protect yourself. You're working in the healthcare environment. That's what you signed up for. So you have to protect yourself. If you're in an environment where they're telling you, we don't have utility gloves for you, or we don't have an HVAC system here, we're not going to use filtration, then you have to have a moment of clarity and ask yourself, is that a place where you want to be working? Are they thinking about your safety? Natalie, we actually have a course coming up on water safety, and it's also available on demand. Yes, the quiz does ask for a passcode, and that is going to be announced at the end of the presentation. All right, so ultrasonic scalers, many of our hygienists here this evening and our dentists that are using ultrasonic scalers emit ultrafine particles. Most of those the particulate matter is ultrafine. You want to make sure that you are connected to a water source that is being tested and treated, that you're autoclaving your ultrasonic scalar parts, right? The sleeve. Follow your manufacturer's instructions for use. If you're being told that you don't have enough hand pieces or you don't have enough ultrasonic scalar sleeves, etc., so just barrier protect it, I'd be running from there, okay? Because of biofilm. Biofilm is created within the handpiece, and that includes your prophy motors, and also within the sleeves of these handpieces for your ultrasonic scalars. So follow your instructions for use. Look up your IFU. If you're using equipment today and you've never looked at the IFU, that is your homework for this evening, because you cannot maintain and use equipment and not know what the instructions for use are. And you might have been trained on the job, and so you may not have been trained properly to maintain this equipment, but your hand pieces have to be autoclaved because biofilm forms inside of those hand pieces, and when you turn them on, connected to a water source, you're going to spray out whatever that biofilm is into the operatory, and you're going to inhale it. And we just talked about ultrafine particles. So we want to try to reduce the possibility of manufacturing these ultrafine particles to begin with. And there's quite a bit in your power to do that. I'm going to be talking this evening, and Glory will, about how you can monitor your air quality in your practice using a device that's about $300. You can see the quality of your air in your dental practices and outside your dental practice. All right, so ultrasonic scalars test here in this study demonstrate the highest concentration of small droplets in zones, of course, nearest the patient, less commonly up to 8 feet away. In mitigation, we should emphasize source control. We want to try to capture as much of that aerosol as closest to the patient as possible. High-speed hand pieces data demonstrated here that they tested for 4 dental procedures: restorative, generate splatter or spatter, droplets, and aerosol contamination at 120 centimeters away from the source. And among these 4 procedures, the high-speed handpiece generated the most contamination. When you run a high-speed handpiece, it creates a vortex that's going to suck back in saliva and what other materials from the patient's mouth into that handpiece and spray it back out again. So you need precautions for reducing aerosol, droplet, and splatter contamination from these aerosol generating procedures. And again, you're going to hear Glory talk about monitoring the air quality. You can actually test your various procedures in your practice and find out if you can change procedurally what you're doing to reduce the amount of aerosol you're producing to begin with. And in many cases, you can. Okay, laser sheet imaging of aerosols during a dental procedure. So this was at the University of Minnesota, and they tested several filtration devices to try to increase health safety, particularly during COVID-19. But newsflash, we had an aerosol problem before COVID-19. COVID-19 brought it out here and put it in our faces, right? That we needed to do something about this. We needed to have good source control, for instance. So I'll show you a quick video here, and they used laser imaging. For those of you, there's really no discussion here. It's mostly demonstration. . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . .
So both are on. 3, 2, 1. Both are on. 3, 2, 1.
So you can see this laser. By the way, that is not ultrafine particulate matter. You cannot see ultrafine particles. So that is just what is being emitted in this testing. And the link is there for you if you could not see it. So again, this is demonstrating the amount of aerosol and splatter that's released during these procedures, and why we want good source control. We want to capture as much of that as possible closest to the patient's mouth. Okay, some of you are asking quiz questions before we got to that part, so let's refrain from that and let me give you the presentation. And when we get to that question, I will emphasize it for you. So research concluded the use of the electric drill rather than an air-driven handpiece led to a 99.98% reduction in aerosol spread of the virus, SARS-CoV-2, into the air. And when they added a dental evacuation device, there was no detectable virus on surfaces or in air samples taken 6 to 10 minutes afterwards. So results here in this study showed that by replacing air-driven high-speed handpieces with electric low-speed drills, aerosol spray was virtually eliminated, creating a safer environment for patients and the dental team. So that should answer your questions and the quiz. All right. Aerosol reduction during air polishing. The concern here has been expressed about the obvious aerosol cloud that is generated during air polishing. If you are using air polishing right now or guided biofilm, etc., mitigation, which has been around a long time, sodium bicarbonate air polishing, which I happen to love, has been around a long time. But I've had to inspect dental practices for dental boards and health departments in my previous life. And if I walked into an operatory where they, especially hygiene, and they were using air polishing, I could take my hand across the wall or the counter and pull it up, and it's got a fine powder on it, right? Because we're not capturing it all at the source. And the concern here is the potential systemic effects and infection control and these environmental surfaces that are contaminated with the particles of sodium bicarbonate powder, water, and of course the organic material from the patient. So using an aerosol reduction device, especially very good source control, is really required here. The air-water syringe bacterial counts indicate that airborne contamination is nearly equal to that of ultrasonic scalars. High-volume evacuator will reduce the airborne bacteria by nearly 99%. And that is from 2004. That was 20 years ago. And that's Dr. John Molinari. So again, aerosol has been an issue probably before some of you were even born. All right, airborne dispersal of low-risk and high-risk HPV DNA during ablation of HPV-associated lesions is well documented. Laser procedures in dental practices generate aerosol and contamination, all right? And this was a case where gynecologists that were removing HPV lesions with either LEAP or laser, CO2 laser, generating laser plume and then inhaling it, developed HPV lesions in the oropharyngeal area, and they were serotyped to be the same source. So very important if you are using lasers in your practice that you have the correct source control as well as ventilation in your practice. And again, I would recommend looking at monitoring your dental air quality in your practice. You might be very surprised. All right, so infectious disease can be caused by aerosol from person to person, and these are various, rhinovirus, tuberculosis, influenza, Legionnaire's disease, SARS-CoV-1 and 2, other bacterial, viral diseases, and fungal diseases. And infectivity and virus shedding of emerging and re-emerging viruses. Not all viruses are as robust. Some will not live on a surface for very long. This is ID50. So the infectivity of a virus refers to its ability to initiate infection of a host cell with production of viral progeny, being able to replicate. So the infectious dose 50 is the smallest number of infectious virus particles that will lead to infection of 50% of an exposed population. So dependent on species, age, or race of the host, the receptor that it binds to, the immune and nutritional status of the host or host tissues, and the portal of entry of the virus. So we're going to finish up here pretty rapidly. So in the case of most viruses, only a percentage of those infected actually develop clinical illness. But there are some viruses here that are highly, highly contagious. Ebola is one. Ebola, one viral particle can cause disease transmission in some cases. One viral particle, 1 to 10 aerosolized Ebola virus particles can cause an infection in humans. Influenza strains, 100 to 1,000 infectious viral particles, and SARS-CoV-2 thought to also have low ID50 values. Viral shedding is referring to during the prodromal period before actual appearance of symptoms, as well as once symptoms appear, the infected individual may become a shedder of infectious particles. And that's problematic. We call those carriers, right? Carriers can continue to shed viral particles. So that can cause disease transmission to you and your patients, and they can become aerosolized. We have that situation with COVID-19. The patient can enter your practice right now. They can sit in your dental chair. They can talk to you, do not feel sick a day in their life, shed viral particles, and have SARS-CoV-2, have COVID-19, excuse me. If you tested them, they would test positive and never feel sick. Or they may feel sick a few days later. So virus survival in fomites via aerosol. Fomites are inanimate objects, could be on a surface, instruments, and so forth. Engineering and administrative controls. Healthcare facilities and settings should use engineering and work practice controls to reduce worker exposure to generated aerosols to the extent feasible. So administrative controls mean reducing the risk and placed in the hierarchy of all other controls before engineering. So you all are the experts at administrative controls. You deployed these at the beginning of the pandemic. What did you do? You wanted to make sure that sick people did not enter your practice, and you still want to make sure of that, right? But you use different things to get a sense of if this person is someone that should be reappointed for another day, for instance. So let's say you ask them to fill out their health history online, and you're asking questions. Have you tested positive for COVID-19? Has anybody in your household tested for COVID-19? Have you traveled anywhere, et cetera, et cetera? Have you felt sick? They come into your practice and now you're taking their temperature and so forth, right? Those are all administrative controls. We place them above all the other controls. Engineering controls, we use devices and protocols to mitigate risk. What would that be? The rubber dam, which is an excellent device to help reduce aerosol. Many of you may be still using a rubber dam. HVAC, certainly extraoral scavenging devices, UVC, foggers, and pre-procedural rinses, and more. Extraoral scavenging devices in this study resulted in a 20% reduction in frequency and 75% reduction in mean intensity of contamination of operatory sites. There was a 33 and 76% reduction in mean intensity contamination for the clinician and the assistant, respectively. When they added rubber dam and four-handed dentistry, it resulted in further reduction. Engineering controls, what do we use? Well, in this case, an extraoral suction. So we're mitigating risk when we deploy engineering controls. Extraoral suction units are an effective method of reducing droplet spatter during operative dental procedures. Source control, again, and can be useful in helping reduce the risk of experiencing COVID-19 spread during dental procedures as well. They use the extraoral suction unit at a level 10 at 4 inches from the patient's mouth. And you'll see that droplet spatter occurs very close to us. We're close to the patient at eye level. You'll hear Glory talk about source control as well, and the scavenging devices that they have. All right, far UVC light is a new tool that is being used for surfaces. There's some controversy whether it's something we should use in our HVAC system. You will hear Glory talk about how their studies indicate actually causes degradation of the components of the HVAC. And you need to make sure that UVC is doing what it's supposed to do. Is it going to kill what it's supposed to? Masks, again, N95 are recommended, especially now during high flu season and so forth, but they should fit correctly. And there's some information about respirators, N95 respirators there, and a graphic from the CDC. And your operatory specific applications by room and area. And you're going to hear Glory review this as well. The operatories, source control, so intraoral devices, extraoral scavenging, individual room filtration, HVAC, UVC. Consider reducing the amount of stuff you have on your surfaces, the objects. If you've got the little glass jars with the cotton rolls and so forth, I would just get everything off of there that you don't need so that you have a nice clean surface to deal with. Make sure that your PPE is covered. Reception area needs the love too. So HVAC as well as individual room filtration, dental laboratory, again, benchtop filtration, HVAC, potentially with UVC. Your restrooms should have good filtration too, because every time someone flushes a toilet, they are creating aerosol. And it's good to treat the water. And this is just more information about what you can do about your restrooms if they're in your practice. Dental practice design, what is it going to look like in the future? Back in the old days, when I was a dental assistant, we had closed bay operatories. They were individual rooms. And that sort of changed over the 80s and 90s because of cost control and design. We may potentially be going back to closed bay. There's resources for you. There's a link to our infection control course. It's live each month, also supported by IQAir, and we want to thank them for that. I'm going to go ahead and bring the code up for you. 285931 is the code. Mary, if you're struggling with the question, I would say in the interpretation, go ahead and answer it because you're going to be able to see the correct answer. I don't know which evacuation device that was in the video, Mindy, and you're going to see one from Aerosol, IQAir on their aerosol recommendations. I have not used Relief, but I think anything for source control is important. Any information on paint that's developed for hospital walls to decrease pathogens, you still have to clean the surfaces. So, yep. Most aerosol is from air-driven handpieces. That is correct. Rubber dam is an administrative control. That is for you to answer based on the information we just gave. What are my thoughts on the woodpecker system? It uses a fine spray with erythritol similar to the Cavijet. So anything that creates spray like that requires a couple of things, Lan, and it's a good question. What are you using for the liquid? Are you using distilled water? What is making that water? Because that system has to be monitored too. All right. Anything that creates a fine spray is creating aerosol. So you have to have an extraoral scavenging device would be my recommendation, and intraoral as well. You're welcome, Lisa. Thank you. Is rubber dam considered administrative control? I'm going to have you come to that conclusion. Jordan, please refer to the screen there. I'll put the quiz link in the chat area for you. Again, some of these you'll have to just answer the quiz and you can check your answers before resubmitting. I'm going to put the quiz link here and I'm going to ask y'all to stay on for a few minutes to hear from Glory Dolphin-Hamas. And she's going to talk to you about solutions for your dental practice. Okay, so we're going to post this in the chat area. And again, 285-931. Let's watch a quick demonstration here from Glory Dolphin-Hamas. I'm not used to seeing myself so large on the screen. Okay, I'm going to introduce you all to Glory Dolphin-Hamas. And again, we said Glory is an expert on aerosol management, filtration, HVAC. She sits on the EPA governmental committee for the EPA and so forth. I'm going to give you the quick abbreviated here because I want you to see her video. Ask questions by posting them in the chat area for Glory. And on the top of the screen, you're going to see a way to reach out to IQ Air as well and learn more. This presentation, a copy is in your course folder.
Let's talk about solutions for dental practices, how to improve the air quality in dental offices, operatories, and waiting rooms. The execution of dental work increases the risk of exposure to a wide range of potentially harmful airborne contaminants such as viruses, bacteria, and also other dangerous aerosols. That means that the risk of airborne exposure to airborne pathogens the risk is significantly higher than in most environments. And it's really that the use of high-speed drills, ultrasonic scaling, equipment generates fine droplets, also ultrafine droplets, essentially aerosolize particulate matter that are light enough to stay in the air for hours and sometimes indefinitely. Particle size does matter. In terms of sheer volume, it's actually ultrafine particulate matter that make up over 90% of airborne particles. Fine particulate matter accounts for about 9% of airborne particles. So fine particulate matter that is between the size range of 0.1 microns and 1 microns. Then you have really coarse particulate matter, and that accounts for less than 1% of all airborne contaminants that are in the air. Let's take a look at this video. This video shows essentially what the air quality looks like in a 10-15 minute procedure. So what we can actually see with the naked eye is coarse particles. So we actually cannot even see fine particulate matter with the naked eye. And let alone ultrafine particles, which account for over 90% of particulate matter in the air. And what that means is that there's a whole lot more particulate matter when you're talking about counting fine and ultrafine particulate matter, because the only thing that we can see with the naked eye is the coarse particulate matter. So that this just shows that we're actually only seeing 1/100th of the particulate matter that's there in terms of sheer volume. Okay, there are actually 3 steps to improve air quality. First step is source control. And by the way, I'm actually presenting these steps in order and prioritization order of importance. So if there was only one thing that you could do and one thing alone, you would want to do source control. So this is a prioritization order, and I get this list. This is not my personal list, but this is actually the list coming from the Environmental Protection Agency and what to do to improve air quality for all types of environments. So number 1, you'd want to do source control. Number 2, you'd want to ventilate. Ventilation is also known as dilution. So when you think about ventilation, think about diluting the air and introducing a new source of air into the room to dilute the amount of concentration of particulate matter. Also, step number 3 is recirculation or air cleaning. And often, even through the pandemic, the first thing that we actually thought about was actually air purifiers and getting an air purifier in general. But as we see when we look at this prioritization list in terms of improving air quality, that is actually number 3. And we should be really truly looking at source control and also ventilation as well. When it comes to source control, wanted to mention that extraoral suction. You probably heard of that within the dental environment. Extraoral suction allows aerosols to be captured at the source. And just a little bit step further, in terms of air quality and improving the air quality, you've got to start with measuring the air quality. We've got to actually quantify how clean, or in some cases, how dirty the air might be. That's what we do with the Air Visual Pro and also with the Air Visual Outdoor. It is our air quality monitoring platform, and it's very important that you, as a facilities owner, that you understand where the state of your air quality actually is so that you can improve it and make it better at all times. So that's what this actually allows you to do. And what we do in terms of air quality, we actually measure outdoor air quality, and that's what's called baseline. And it's always good for us to clean the indoor air, and we compare it to the outdoor air. How much cleaner is the indoor air in comparison to the outdoor air? Good question. I'll answer that. We have Clean Air Facility. This is our particular clean air facility in La Mirada. This is IQ Air La Mirada, and you can see how much cleaner the indoor air in comparison to the outdoor air is, and it's 100% cleaner. With the clean air facility, you're able to achieve approximately 90% cleaner air, and that's according to baseline outdoor air. So we're going to talk a little bit more about source control. First, you measure the air quality to understand where you want to be in terms of air quality. But when it comes to the dental environment, in terms of source control, you actually want to remove the source of airborne particulate matter as it's being created. And that's through the use of a device. It's called an extraoral suction device. And it actually vacuums away in a suction-like manner the particulate matter that is being created, and it does this as the particulate matter is being created. So this is a very important tool. With our IQ Air FlexVac, we're able to achieve 90%, actually 92% effective capture rate when this device is within 12 inches of the patient's mouth. And that's a very big improvement in the air quality and removing what's being generated in terms of aerosolized particulate matter. So we just spoke about extraoral suction. This is a picture of extraoral suction device. There, the FlexVac. The other way to improve air quality through source control is through the use of the AirVisual Pro. By being able to measure, you're actually able to make procedural improvements. You're able to see what would make the difference in some cases if you add water spray, if you add certain steps, and I'm sure that will be talked about in detail. And these different steps that you can do, these can create quantifiable improvements in the air quality. And I know that there's quite a few dentists that experiment with this, and you're able to do that with the AirVisual Pro. You're able to go from room to room. You're able to measure before the procedures, after procedures, and it's able to really give you quantified details in terms of how the air quality is doing and what improvements you can make that result in producing less aerosolized particulate matter. Okay, so a rule of thumb is that extraoral suction is the key. We do have procedures that produce aerosolized particulate matter, and it is important as that particulate matter is being created that it's literally being removed from the air as it's being created. And we know that we can do that with a 92% capture rate on the IQ Air FlexVac. Procedural improvements also go a long way, so please keep in mind that there are procedural improvements that you can do that help to minimize the release of particulate matter in your procedures. Step number 2 is ventilation. So if there's access to the HVAC system, we have induct ventilation, we have induct filtration, the NanoMax system that's installed, and this provides mechanical ventilation as well as filtration, and it's a great option if the building, the building has HVAC. It's a great option. If there's an older building, then mechanical ventilation is the option, and that's opening your doors and your windows, introducing an outside source of air. Step number 3, air cleaning, placing an adequate amount of air purifiers within the waiting room. One Health Pro Plus will be able to cover an 1,150 square foot space. So that's also something to keep in mind when it comes to air cleaning. So our solutions engineer can help to assess your practice and provide a solution report to achieve 90% cleaner air with our Clean Air Facility program. Great. Ventilation, HVAC or mechanical ventilation. Let's talk about that in detail. We have a product, it's called NanoMax. It actually is able to achieve better than MERV 16 filtration. It's able to do that because it has a pretty high surface area, lots of pleating surface, and it provides a low pressure drop across the filter, and it works through the HVAC system. It's essentially a 2-inch filter. And with this 2-inch filter, you're able to have just a pretty substantial increase in airflow. If you've had a MERV 11, MERV 13, this NanoMax filter is able to have a lower pressure drop than most MERV 11 and MERV 13 filters, but providing a higher efficiency through the technology that it incorporates. Great. And in terms of step 3, we're looking at air cleaning and recirculation, and it's important that we don't forget about the 8% when we're capturing at 92% rate. there's still that 8% to think about, and how will we be able to remove the aerosolized particulate matter from our procedures when we're only capturing 92%? What happens to the 8% that's floating around? That's what we do when it comes to air cleaning and recirculation. Great. This is Dr. Garcia's orthodontic facility in Miami. Nice office there with the nice lighting, and you can see there the Health Pro Plus in the waiting room. Great. This is his practice and what it looks like, and this is an open bay system that he has here. He has the dental HV flex back, and as he moves from patient to patient, he is using the extraoral suction device in order to remove the sources of particulate matter when it comes to aerosolized biocontaminants. Great. This is Dr. Kelly Blodgett, and he's also working with the IQ Air Flex Vac with a patient, and it is really in a good space when it can be 12 inches away from the patient's mouth, and you can see the patient is also pretty happy with that as well. Great. Any comments? I'd love to hear your feedback as well. And you can also visit our dental solutions page and reach out to us, and a solutions engineer will be able to help you. You can also schedule a call as well, and folks will be able to help you and give you a 10 or 15 minutes, if you have 10 or 15 minutes to spend with them, how you can achieve cleaner air within your facility. Thank you so much.
Welcome, Glory, and sorry, my head is so big. I usually don't have it on this one, but it's big. I want to introduce everyone to Glory Dolphin-Hamas here, who's the CEO of IQ Air, and she truly is an expert in aerosol for all of your dental practices. At the top of the screen is a banner. If you tap on that banner, it will take you to their information page, and you can bookmark that URL and change it, share it to your device. So welcome, Glory. Thank you so much for being here.
Thanks for having me. And your head's not big at all.
It feels a lot bigger than that little square at the top. Let's see here. Can you talk a little bit about the UVC that some may have in their systems?
Sure. And within HVAC, we've actually found that it can help to reduce mold growth, what's called the cooling coils. But as an air cleaning sort of aid to filter out or to reduce the amount of biocontaminants, we found that as far as R&D, it hasn't been very effective in terms of its efficacy, just due to high amount of contact time that's required. And this high amount of contact time hasn't been achievable within an air cleaning device, as the air is blowing by so quickly. The use of actually putting UV on the filter itself hasn't produced any results in terms of better filtration. But over time was able to, in some ways, break down actually the filter material so that it was compromised through just radiation over time. It was able to form these microscopic holes and actually compromise the integrity of the filter itself.
Okay. And in terms of the monitoring, the visual, do you have to have any sort of other equipment? I mean, can you just take that device from operatory to operatory and test what you're doing, your procedures, and take a look and maybe see if you want to change what you're doing a little bit? Maybe you want to use a rubber dam or something like that. How portable is it?
It's portable, and it actually has, I think, about 6 hours of battery life when it's disconnected. So when it's fully charged, you'll actually be able to take it around in your hand and put it in the various places within the practice. And it's very much so eye-opening. So this will probably be your beginning as an air quality nerd, and you'll probably be able to really get into quantifying how clean the air quality actually is and how to get it cleaner and cleaner over time.
And you have also devices and so forth for the home, for vehicles, for traveling, for your desktop. Right now, I happen to be in Pittsburgh again, and I walk out in the morning, and it's like a sulfur factory. It's just the mills start on a Monday, and you can smell it. It's familiar to me growing up, but it's not something I was planning on being here now and then. So I'm going to get this for our offices on the East Coast because I want to know what's going on. Any questions for Glory, please let us know, and go to that banner at the top of the screen so that you can save that URL and take it back to your offices tomorrow.
Sure. There was one question about splatter. It really depends on the actual particulate, the diameter. So depending on how small this particulate matter is, if it's small enough and lands in what's called ultrafine, 0.1 microns or smaller, it can stay in the air for hours and sometimes indefinitely if it's small enough.
There was a study that just came out here last week, and I wasn't able to add it to this presentation yet, but I'm going to, on exposure to ultrafine particles and oral health. Actually, there's some effect on oral health as well. So ultrafine particles are really a risk to all of us, whether or not we're in a wildfire zone or not. Timothy would like to know, what is the cost to start?
I would recommend getting a Air Visual Pro, and that's very eye-opening, and that's really the beginning. And you talk so much, Dr. Kirsten, you talk so much about the different methods and the different products that you can use in order to reduce your particulate matter level. And I think the best thing is to know what those levels are and to really take the time to introduce new methods, new products, things like that, where you're able to quantify, is it getting better, the air quality, or is it getting worse?
Absolutely. And I think for our hygienists out there that are using air polishers, I think it would be really interesting to take a look at that as well, because if you're not using some dedicated extra oil scavenging and source control, like Glory said, you are probably going to be shocked at what you're creating in your practice. I've seen it and I've experienced it. Any other questions or comments? Glory, how often do these filters need to be replaced?
The pre-filter would need to be replaced about every 10 months on average. But the good thing is that these filters actually have a sensor, and you're able to know exactly when they need to be changed. I believe the gas phase filter lasts approximately 3 years.
Wow.
And that's also the post filter as well. So we're looking at this pre-filter about every 10 months and about every 3 years for the big gas cartridges and post filter sleeves.
Are the gas cartridges, are they, and the device, is that something that can be used if you're in a clinic where you might still be removing quite a few amalgams, especially public health clinics, and we're worried about, mercury vapor and so forth? Is that device better for that sort of situation?
It is, but also you'd be surprised how many TVOCs are actually present within the dental environment. There's quite a few in terms of concentration. There's
Really? Okay.
Concentration. Yeah.
Okay. I'll have to add that to my presentation for next time. Any other questions? All right. Well, you have a copy of this presentation in your course folder. Gloria, I want to thank you again for being here and helping me out. And I learned something new every time. And I want to encourage everybody to reach out to IQ Air. And I know there are a couple of you that are already using the system, but it really truly is top of the line for your practice. And you can't, this isn't something that you want to skimp on just because you can't see it, because it is affecting you on a daily basis. So thank you so much, Gloria.
Thank you so much. Thanks for having me. Have a good one.
Thank you.
Thanks.
Bye now.
Bye-bye.
Okay, everyone, I am going to answer any other questions here that you might have. I will put the code up on the screen. And again, you do have a copy of this presentation in your course folder. You can reach out to Gloria and her team at IQ Air. So there is the code one more time, 285931. (285931). And anybody need assistance with the quiz before we close? That's good, Sherry. Yeah, definitely reach out to her. She's a great resource. I am not still at a clinic. I have retired from clinical practice. For the most part, I consult. I've been in dentistry since 1981, so I teach mostly full-time now and consult for other clinics and practices. Share my knowledge. All right, does anyone need assistance? I'm going to tell you all good night then, and be sure to reach out with any questions. Parts per million for EarthSafe is 4,306 parts per million on the concentration. That is for NADCC tablets for the concentration that you need to kill Clostridium difficile spores. 4,306 parts per million. And that is a 4-minute wet contact time. If you use an electrostatic sprayer, you are going to get more of a fine wraparound mist. And it's really about using the dry wipes with their product. Wipe off the high touch areas, the dental chair, and then everything else come in with a sprayer. I don't even know how I remember that. All right, I would like to tell you all good night. Tomorrow night is a course I'm presenting on xerostomia. And then on Friday, we have Dr. Palmier, who is presenting all day, the first 4 hours on the new dental antibiotic guidelines, and then followed by opioids, dental pain management for 2 hours. So if you are in need of that course and you would like to learn from a globally recognized expert, which he is, he's one of the co-authors of the guidelines for the American Dental Association, hop on the website. I think the live course in the morning may be pretty close to being full. How long will splatters stay in the air? Not for more than 2 hours. The heavy particles are probably going to fall to earth pretty quickly, as opposed to droplet nuclei, which are going to hang around in the air currents for some time because they're very light in mass. All right, everyone, I am going to tell you good night. Thanks so much for being here. Please check out the website. We've added new classes, and thank you for joining us.